So again, I would like to thank the organizer for this opportunity to be uh, here to speak on this important topic. Since the morning, we all understand that even with this desensitization, the patients do well as compared to the patients on hemodialysis. So we have this chance that for the better survival, better outcome, we can desensitize some of the sensitized patients for the better outcomes. When we look at the barriers of the ABO and HLI, one of the important factor is the severe antibody-mediated rejection. Whenever you have anti-A, anti-B, that binds to AB antigens, and then there is activation of the complex activation of complement factors. And this C3A and C5A is actually the chemoattractant. You might be looking at the biopsy. When you see the biopsy of the severe rejections, you have a lot of neutrophilic infiltrates rather than lymphocytes, and you have a lot of eosinophilic infiltrates. So this is the reason why these patients on the histology, you have a lot of infiltrations with the polymorph nuclear cells. When we understand about the significance of ABO incompatibility, until mid-90s, very poor survival, 4% at 1 year. And Chug and colleagues has revealed that 8 of the 10 ABO-I patients failed within a few days after transplantation. And the success comes once pupils have realized that A2 has the least immunogenicity and very poor expression on the cell surface. So it was possible that probably from A2 donor, you can have the better outcome of ABO incompatible transplantation. But major concern always that you have the very little prevalence of the A2 blood group donors in our populations. So how safe is the crossing this barrier? Usually, most of the patients during these years of the dialysis gets blood transfusions, pregnancy unavoidable for many times in the ladies, and repeat transplantation. Whenever you have this any development of anti-HLA antibody, we say that probably this patient is sensitized. Whether this is severe sensitization or it might be the mild or moderate grade of sensitization. So characteristics of HLA and ABO antigen, since the morning we understood that probably anti-A, anti-B is the antibody against carbohydrate antigen, and it is very easy to desensitize this group of the antibody, and the accommodation happens very soon. So probably you do not have that much of the fear. And reappearance of this, again, anti-A antibody do not cause too much of the harm. There is no fear of the de novo antibody as it happens in even after accommodations in HLA antibody. Anti-HLA antibody is very difficult to desensitize, and de novo appearance is also very common. So it is always very challenging to desensitize anti-HLA antibodies as compared to anti-A, anti-B. So there is a difference in the accommodation in ABO-I and HLI. How it is different, I am giving you some examples. Upregulation of the protective factors, anti-apoptotic factors like HO, heme oxygenase 1, BCL2 and BCLXL. That apoptosis we know, programmed cell death since our MBBS days. Complement regulatory proteins like CD46, CD55 and CD59, enhancing their ability to repair injury and maintain function. Clusterin, also known as the apolipoprotein J, is a chaperone's protein with anti-apoptotic functions. So all this helps in the rapid accommodation in ABO-I. Modulation of the immune response also happens. Low affinity of anti-A, anti-B antibody in the recipient gradually adsorbs more dangerous high affinity antibodies. So that has the, again, neutralizing effect. Amongst the host factors, shift from Th1 to Th2 immune system, immune phenotype, again, that helps in accommodation. And it is thought that probably gradually over the times, endothelial cells of the donor is replaced with these recipients, and the accommodation happens. So pathway differences of accommodation in HLA-I. ERK1 and 2 inactivation after anti-A antibody ligation is important. But what happens in HLA-I? When HLA incompatible patient is there. Protection from the external stress and apoptosis happens with PI3K or AKT signaling. So this pathway is totally different. And this allows only if you have the very low titer of HLA antibody. If you are low titer, you can get accommodated, but very high titer, it is very difficult to get accommodation. So this is the major difference in the accommodation process between the ABO-I, and there is a little more accommodation differences in bone marrow transplantations. Again, that is a different mechanism. So all are different. We should understand this is a very difficult pathway to get accommodation with high anti-HLA antibody titers. So we are coming to some hard facts that where how anti-HLA antibody is causing more harm in ABO incompatible transplantation rather than only anti-A, anti-B. Here is the one study. Here we can see ABO-I kidney transplantation 70% and compatible patient 304 patients. Where you can see HLA DSA less than 5,000 versus HLA DSA more than 5,000. ABO-I group 58 and ABO-I HLA antibody. What you can see in ABO-I and control group, similar rate of the survival. But even with this ABO-I with HLA, anti-HLA antibody or HLA antibody alone, even in compatible transplantation, survival is lower. So survival is mainly affected with basically with HLA presence, anti-HLA antibody presence in ABO incompatible transplantation rather than anti-A or anti-B. So here we can see overall antibody mediated rejection episodes, overall infection episodes were not different. Again, here we can see, but post-operative bleeding was a little bit more, probably because of the more requirement of immunoadsorptions or plasmapheresis in ABO-I plus anti-HLA antibody groups of the patient. So anti-ABO or anti-HLA antibody titer in the rejection post-transplantation, here we can see ABO-I or ABO-I HLA. Majority because of, not because of anti-A antibody, mainly because of the anti-HLA antibody. And all 4 antibody-mediated rejection cases from ABO-I HLA groups had rejections because of the presence of the anti-HLA antibody, not because of anti-A anti-B. So prediction of antibody-mediated rejections by HLA-DSA or anti-AB titer at the baseline. Here was the one evidence that has shown if you have a strong HLA-DSA of more than 10,000 at baseline compared to patient with the negative or weak HLA, anti-HLA antibody of less than 5,000 or moderate DSA at the baseline, you can see the acute rejection rate was higher with the strong HLA groups. Then baseline titer of the anti-A, anti-B also was important. And one of the study has shown those who have baseline titer of anti-A, anti-B of more than 1:32. These patients were more likely to develop, again, anti-HLA antibody and related rejections. Here, we can see the only factors which are predicting were a strong HLA-DSA in ABO incompatible transplantation, which was causing these problems. This is our own data published few years before in Transplantation Direct. What we can see here, again, those group of the patients who have preformed HLA antibody had the poor outcomes. 2 patients had very severe rejections. 2 patients had anti-HLA more than 5,000. We have done the desensitization when the titer came below 1,000. But again, there was some rebound and the patient had a rejection. So acute antibody-mediated rejection in living ABO incompatible transplantation, one long-term study is here. Here we can see multivariate analysis demonstrated that anti-blood group IgG antibody titer of 1:32 at the time of transplantation or donor-specific anti-HLA2 are anti-HLA were independent risk factor for antibody-mediated rejection regardless of the baseline anti-blood group. So is it important to go down? Many people are very much happy with that we are doing transplantation at titer of the 64, titer of the more than 32. So that is something which is alarming. We must bring down the titers, because one of this antibody potentiates the activity of the other antibody. So that was the message from this study. So now this is our own study showing the ABO incompatible twin barrier 5 patients, which we have initially done when we have started ABO incompatible transplantation. Out of 5 patients, all done well, except one patient had a death after 65 days because of the severe rejections. Uh, and then rejection followed by treatment and then infections. So desensitization protocol and immunosuppression used was, here we can see some of the patients were the repeat transplantation again in this group of the patients, and majority, most of the times we get rid of. But when we follow this patient, you would have the very early recurrence of proteinuria. When you do biopsy after some times, you might have the transplant glomerulopathy like changes there. So this was the one scientific reports study that has again shown that the blood group A, B or anti-HLA antibodies show synergistic activity. So that what I was telling about time and again. If you have the titer of any antibody there, it is possibly potentiating the other antibody. And here again, factors associated with acute rejection during the first year of the transplantation, what we can see. DSA of class 1 has a higher chance of when on multivariate analysis. DSA class 2 MFI of more than 1000 was again associated with higher risk of rejections. And definitely if the cross match positivity is there in the beginning, even after desensitization, we have successful transplantation, graft loss is very high, even of that has been shown on multivariate regression analysis. One of this important paper, what I can show you, this was the heart transplant patients cohort. They have shown really after the sometimes the appearance of, although in class 1 antibody comes back, but in this neonatal heart transplant group, what they have shown, probably class 2 antibody is not coming up. They have followed this patient of the heart transplantation subsequently. So that was the one lesion probably. If you are doing early, particularly in the neonatal heart transplantation program, class 2 antibody was not reappearing. This is SGPGI experience of the class 1 and class 2 DSA, sensitized ABO incompatible transplantation. Baseline characteristics was almost normal in all groups. What we have seen, this was graft survival. I'm coming back to here. Those who have HLA antibody, 10 years survival, because we have started first transplantation in 2013, so now we have long follow-up, was 70% in HLA sensitized, those who have some antibody, as compared to 81%. So it was approximately 10% lower when you follow these patients, those particularly those who have this antibody, anti-HLA antibody. And death-censored graft survival is also lower. And this happened mainly because of the 2 patients died early because of the non-compliance. So when we think of the post-transplant infections, as we have the debate here, we can see early CMV infections was higher in those group of the patient who are sensitized, probably received more immunosuppression. Otherwise, there was no difference in other infections. So to conclude, ladies and gentlemen, long-term outcome is numerically poor in HLA sensitized in ABO incompatible transplantation. However, statistically not different. There is possible interaction of the 2 antibodies post-transplantation potentiating anti-HLA antibodies. However, the study underscores the feasibility and safety of ABO incompatible kidney transplantation in those who do not have anti-HLA antibody. So thank you, ladies and gentlemen, thank you. But one of the very important of this diagram, this was a propensity match score of those patients who develops rejection in ABO compatible and incompatible patients. These are just accepted in Journal of Nephrology. It might be coming in the next issue. Here we can see those who developed rejection, ABO incompatible kidney transplant recipients, overall graft survival is only 50% as compared to 79% with ABO incompatible transplantation who had biopsy probability. So this is the propensity match score. So it appears that probably if rejection happens in patient of the ABO incompatible transplantation, this would be likely to be more severe, and reversibility chance would be relatively less. So, but long-term survival, we all understand, is comparable. That is the Japanese data. Again, this has been shown by Dr. Bansal and Dr. Fuller again. There is higher risk of infection in ABO. But take-home message that anti-HLA antibodies are associated with poor graft outcomes in ABO-compatible transplantation. Anti-A, anti-B are antibody against carbohydrate antigen and easy to desensitize. Accommodation is easy with ABO-I as compared to anti-HLA. ABO-I should be performed preferably in patients without anti-HLA. Anti-ABO antibody may potentiate anti-HLA antibody. So these are all from my side. But in the last but not the least, I will invite you all to register yourself. Any problem, let me know. ISNCon 2025 is going to happen in Lucknow at SGPGIMS. So this is my kind invitation. Secretary General of the ISN is also here, Dr. Bansal. So please register yourself and enjoy the hospitality of the Lucknow. Thank you, ladies and gentlemen. Thank you.